Hello, everybody. This is Mark Lynn. This is the Introduction to Rural Health Clinic Program webinar dated April the 30th, 2021. And here I am. Here's my contact information. If you need to get a hold of me, there's my biography. If you need to see about what we've done over the few years. And then Danny Gilbert, she's not with us today. She is off this week. But if you do need to get a hold of Danny, for any reason when preparing cost reports or whatever, here is her contact information as well. Here is a listing of the things that we do. We prepare a lot of cost reports, work on a lot of emergency preparedness, do a lot of RHC startups, and TennCare quarterly reports here in Tennessee. So those are the listings of our services. Webinars coming up in the near future. We have several webinars that are scheduled, one on cost reporting on May the 5th and provider relief funds, and one on preparing for the RHC survey on May the 13th. And we'll try to schedule a couple every month, as we just have so many RHCs that are coming online to be an RHC. And that's one of the reasons why we're having this session today, is we've got a lot of brand new people that are becoming RHCs, and we need to get this information recorded, which I made sure to push the record button today. Somehow on the mental health webinar on Wednesday, that button did not get pushed. So I apologize for that. Another webinar, it's not one that we do, but I highly recommend it. I did it a couple of months ago, was from ArchPro Coding. If you are just beginning to bill as a rural health clinic, this is a 2-day webinar. You can get accredited as a RHCB, something like that. There's a test you have to take. I need to take that test because I went through the training and learned a lot. Got a bunch of coding books here that I've been using a lot since then. So it's a very good session for the price you pay, $200, and I would definitely recommend joining this group. Be a member for $250. It is really, it is money well spent for any of your billing people. So disclaimer, everything is up to date as of today. Spent this morning trying to get everything up to date. So as far as I know, everything is up to date. Questions, if you want to type your questions in the sidebar, I will answer those when we get finished. And if you want to raise your hand at the end, we can open up your line if you want to ask a question. Slides, your slide presentation is in your handouts over there. And if that doesn't work, which go to webinar, it hates my slide presentations for some reason. A lot of times they will not download. I did put them on our website at ruralhealthclinic.com/COVID-19, and you can go there and pull the slides up if you want to print those and take notes as we go through today. So either on the handout session side or go to our website at ruralhealthclinic.com/COVID-19, and you will be able to get the slides. Quick update. Public health emergency has been extended through July 19, 2021. What that means is you can still do telehealth through that time. And the Biden administration has indicated that the public health emergency will run through the end of this year. So that is good news as well. It's not official. The official version is through July 19, 2021. So provider relief funding, still no update on that. I checked it this morning. It still says that it was reviewed March 23rd, 2021, but there's been no update to that. So the portal's open, but you cannot report your expenses as of now. The deadline is still June 30th, as far as we know, on liquidating that money, spending that money, having lost revenues to account for it. Surely it's going to be extended. I mean, they don't have the information out to us, and we're looking at a very short amount of time before, what is it, April 30th, so we got May, June 30th, we got 2 months to liquidate all the money, spend all the money, and do all the reporting. Surely it's going to be extended. Again, not official, but that's the non-update for provider relief funding. Your Medicare cost reports, if you're at 12/31/2020, those are due August the 2nd. If you're one of our clients, please get that stuff into us now. We would like to have a good summer as well, and so we're trying to get those done. I got 2 of them finished yesterday and out the door, and we're trying to get these cost reports done, prepared, and get those to you so we can justify a higher rate to Medicare. So maybe they'll give us that $100 rate that we'll talk about in a minute. Emergency preparedness, that was updated as well. Here is the new Appendix Z, March 26, 2021. What you want to do is read through these 113 pages and look for the stuff in red. The stuff in red is what changed from the previous time. And I have not read it all yet myself. So that will be something to take home with me this week. Take with me this weekend and read the 113 pages and look for the red. From what I've been hearing, it wasn't a whole lot of changes in it, but that's something we will look for. If you are getting your cost report ready for us, what we need you to do is the PSNRs have changed because of COVID-19. And so when you're pulling your PSNR, we need you to ask for a 710, a 715, and a 71S. That's a minimum that we need. If you want to get the 711 and the 71A report, that's fine as well. We won't use it to do your cost report, but there's some good information there. But we definitely need the 710, 715, and 71S. And the 715 is the new one. That's your telehealth and your chronic care management services that we end up having. We have to exclude that cost from the cost report, and this will give us a head start on figuring out what those codes are. Also, the day is April the 30th, and what that means is your quarterly 838 report is due, that credit balance report. If you don't submit this thing in by today, you're gonna get a little nasty gram from your Medicare, from your MAC, saying that you'll get an nasty gram. Your payments will get cut off. And so every quarter, a rural health clinic has to submit a quarterly credit balance report. If you don't do it, your payments get cut off, and invariably that happens to at least one or two of our clients every quarter, and they forget to do it. It's easy to do because it's just a real quick little report that takes 5 minutes to do. You fax it in to your MAC, and it's so easy to forget to do that. So just a quick reminder so you don't get caught in that. Let's start going into the actual or getting close to the actual presentation now. If you're not a member of our Facebook group, it's called the Rural Health Clinic Information Exchange. It's not just healthcare business specialist people. It's pretty much for the whole rural health clinic community. If you've got some information you want to share, please do so in that community if it's appropriate for rural health clinics. And we're up to over 2,300 members now. A lot of great consultants in there that are very helpful. I'm so thankful that they're in there because they answer a lot of questions on there. Our website is called ruralhealthclinic.com, and what we try to do is put enough resources on there where if you want to do your rural health clinic yourself, we put a lot of resources on there, much to the chagrin of a lot of people who say we sort of overshare, and we really do. So all the stuff that we use is really on here. So if you go to ruralhealthclinic.com and go to resources, you will find pretty much everything you need to know about emergency preparedness, certifying, becoming a rural health clinic. We have all of our documents are on there. So like I said, if you're into DIY, you can do it on here. Here's the resources on billing. We have recorded billing sessions from 2020. We need to get out there and update those, but COVID has sort of put a wrinkle in our schedule. Usually every January we try to update those billing sessions, and we've not done that this year. So that's on our to-do list for this summer, is to update all of our billing sessions and get about 4 or 5 rural health clinic 1-hour sessions so that people can do that. And there is a billing test on there. There's about 24 questions on there. I would go through those and get your billing people to go through those because it's a very helpful training tool. If you are becoming a rural health clinic, we have a Google document on there. It's about 15 pages, and it has a lot of great information about becoming a rural health clinic. Again, if you do it on your own, this is a great document for that. Here's our certification stuff and resources here. You can see all, and this has got a long list of different forms that we use when we fill out our evidence binder for our clinics, and that's the most important thing you can do to pass the R8C inspection is to have a really, really good evidence binder. And we rarely have deficiencies because our evidence binders are so good, and they just keep getting better and better as we've learned more and more about R8Cs and what inspectors, what Quad A, and what the compliance team are looking for. So a lot of documents there that you can pull up and use to help you become a rural health clinic. That's the end of our documents there as far as our resources, but this is a new resource and it is fantastic. The National Association of Rural Health Clinics have really outdone themselves on this one here. I will be using this a lot. This just came out about a month ago, but if you go to this website here, it basically tells you, okay, statute, here's the law, this is legally binding, here's your regulation, which is legally binding, and then the guidance. These are things like Appendix G and Appendix Z. And this has already come in handy. I know we had a Kentucky inspector this week that told us we had to do some things that we didn't think we needed to, and we sort of wrote a very sweet, very nice email indicating that, well, here's legally what it says, and here's what the guidance says. Now, what are you telling me? And played dumb, which is very easy for me to do. And sure enough, she came back and sent us a letter saying, no deficiencies in your clinic. We're fine. Those 3 items that you talked about you're good to go. Because and I basically said, well, if I'm telling somebody wrong, let us know. We'll change what we need to do. And we use this to provide the documentation for that. So it's a great resource when you're working with your surveyors to make sure you know exactly what you need to do. Another document or another website that we go to all the time is this Rural Health Centers. This is from CMS. This has tons of documents that you can use all the time, and it gives you updated information, which my one downside about it is it doesn't update this information as quickly as it should. Last year during COVID, this thing was updated maybe once or twice, and we were updating people hourly. It seemed like it was a long period of time there where we were working 7 days a week, 12, 14 hours a day, just on getting information out to R8Cs. And this was not updated as much as it should be. But it does have some great resources in here. It's a place that you need to know about. You need to bookmark. So when there are changes, and right here where it says Medicare certified rural health clinics, you really need to know that link. That link is very important to you because that will take you into something called QCOR. And this is what QCOR looks like. And let me go back, and let me just go over this one update that was on the R8C Information Center. Was COVID-19 vaccines, the administration for our rural health clinics and FQHCs for both Medicare, red, white, and blue Medicare, original Medicare, and for Medicare Advantage plans will go on the cost report. You will not bill for those. So that was an update that was on that website just now. So you need to remember that. I know we get a lot of people that are asking about that. A lot of people say, well, that doesn't make sense. That's not logical. And you're right. It's not logical for the Medicare Advantage to go on there. It's never done that before, but there's a lot of things in Medicare that's it's rote memory. It's not logic. So keep that in mind when you're giving your vaccines out. The administrative cost of that will go on the cost report. Basically, your time for doing that, because you do not pay for those vaccines. So that was an update that we got from that. QCOR, why it's so important is if you go into the rural health clinic piece of this, you'll be able to see how many active R8Cs are out there. And if you're doing your emergency preparedness plan, you're supposed to put a listing of the 4 or 5 closest R8Cs to you and their contact information. This is a location where you can find those rural health clinics to you and get their contact information. But you can know also what's important about it is deficiency counts, citations. You will know what the surveyors are looking for, how many things they've written up, what percentage of clinics have deficiencies in emergency preparedness or in maintenance or whatever. I think those are the 2 major ones that I usually see in there. is preventive maintenance is not being done, and your emergency preparedness plans are not up to date, or your program evaluations are not up to date. It also will tell you 60, and this is, I found this very important, is I put in overdue recertification surveys report. I put in 60 months in there because in Tennessee, where I live, typically the state will come out every 5 years, and they're pretty good about it. You can see, I don't know if you can read this or not, but it says Tennessee, we've had a number of late surveys, 32, only 18% are late. But that means that these, if you're on this list of 32 clinics, you can expect a survey very, very soon. So this information is invaluable to you because you can go out there, and if you're still on this list of, if you know your state surveys every 5 years, like Kentucky and Tennessee, Alabama, the states that I'm closest to, it's typically about every 5 years the state comes out. But if your state comes out every 3 years, just put in that number of months and see if you're on that list. And you'll want to make sure that, not that you're not always in compliance, but you really need to start focusing on compliance. One of the great ways to focus on compliance is the Oregon Office of Rural Health. They have a website, and they have a YouTube channel that every week they have a webinar. And Rhonda Ann Gerst, who is in charge of them, does a great job in putting together webinars every week. You can see here, this is Kate from March the 1st. She did a fantastic job on going over what you need to do to prepare for an RHC survey. And I invariably watch this thing at least once a week. We have meetings with our clinics, getting them ready for survey. And before I do that, I will pop this thing on, and I always remember something different from it. So it's like listening to a beautiful song over and over again when Kate tells about the information that you need to do to be ready for this. So if you click here on YouTube, you'll be able to go watch this. It's about 45 minutes. That's not long. It's great. And then Kate's boss here, Steve Simmerman, he did one of the same similar thing not too long ago from Arkansas. Great information here about, top cited deficiencies, emergency preparedness, mock surveys. I mean, really, really good information for you guys if you're planning on becoming a rural health clinic. These resources will help you to understand what the survey is going to look like, and you can prepare for them. And a great friend, Patty Harper on Inglesey, she just did a presentation on making corporate compliance manageable. And we do ask for a lot of information for you guys to become a rural health clinic. It's a hassle to go through it. We're learning more and more as more and more people are wanting to become rural health clinics. We're getting a little bit overwhelmed with all the stuff that we have to do to get ready for RHC. So this is another great resources. Okay, so finally getting into why in the world do we want to do this, to go through all this agony in the first place? What is a rural health clinic? It's been around since Public Law 95-210. Jimmy Carter administration passed this. The first RHC was in Rogersville, Tennessee, March the 1st, 1978. Was when the program officially started. It is a certification that allows you to qualify for cost-based reimbursement from Medicare and Medicaid. In theory, you should get additional reimbursement from both Medicare and Medicaid. That wasn't always the case, and hopefully that is changing on the Medicare side. But it only affects reimbursement from Medicare and Medicaid. It's not going to change the way that you bill your insurance companies at all. You're going to use the same charge. Don't charge Medicare whatever your RHC rate is. Use your fee schedule. Have a global fee schedule that is the same fee across the board. So that's very important that you do that. Don't charge different rates for different payers. That's not the way Medicare works. What is a rural health clinic? Here is a fact sheet. It's about 8 pages long. It comes from CMS. If you really want to know something about Medicare or a different service in Medicare, if you just type in the name of that service and put in fact sheet behind it, CMS fact sheet or MLN fact sheet, there will usually be a beautiful document there for you that's very simple, that even Mark can understand. It's got lots of pretty pictures in it and lots of pretty tables that will help you to understand that. For Rural Health Clinic, there's an 8-page document. It was last updated May 2019, so take it with a grain of salt. As you're going to see, there's been tons and tons of changes over the last over the last year because of COVID. More change. I've been doing this for, you can tell from how old I am from the screen there. I've been doing this for like 35 years. Never, ever have we seen the number of changes than we have had in the last year to the R8C program. Currently, as of this morning, there's 4,847 R8Cs in the country. Out of the 230,000 physician practices, that represents about 2% of the practices. That's why it's very hard for you guys to get information. You only represent 2% of the physician practices in the country. It's hard for businesses to focus on you unless they're really dumb like me and say, oh yeah, I want the 2%. I don't want the 98% of you. And that's one reason why you have so few resources in your area is, relatively speaking, there's very few of you in the country. Where are they? The areas in black here, you can see Kentucky has a lot of R8Cs, Missouri, Iowa, Illinois, Texas, California have the most. And come here, Tennessee, Mississippi, Alabama, we do have a lot. Other states here have less, and this is all driven by Medicaid. The better your Medicaid programs are, typically, the more R8Cs you will have in those. The states with very poor paying Medicaid programs, they tend to have very few rural health clinics. And you can see from this document here that Kentucky, their Medicaid program is very favorable, Mississippi, Tennessee, Florida, and you get down to North Carolina, very few, Georgia, South Carolina, the Medicaid programs do not pay independent R8Cs very well. I've probably gotten more people out of the R8C program than in it over the years that I've dealt with it, unfortunately. But that's changing rapidly, and we'll show you why. Here is the website if you want to go to find out where specific R8Cs are. This is that QCOR website as well. And then 295 R8Cs have been put in place since 2019. That's important because of some of the changes that are in the works as far as provider-based and independent R8Cs. And thank goodness we've got some good news on that 2019 date. At one time, the law stated that R8Cs that were set up after December 31st, 2019, then the new caps would apply to them for our provider-based rural health clinic friends. That law has changed to where now that date is December the 31st, 2020. As long as you've got your 855A in either PACOS or mailed in to your MAC by December 31st, 2020, your clinic should be grandfathered if you're provider-based. So all the kinks and all the details haven't been worked out on that yet, but that's been the latest law that relates to that. So what are the advantages of R8Cs? Your Medicaid reimbursement can increase dramatically depending on the states. If you've seen one state, you've seen one state Medicaid program. They're different all over the place. And so depending on what state you're in, Medicaid can be a grand slam. A rural clinic can be a grand slam, or it can be a single or a double. I mean, really every state is different. And I mean, it ranges from Georgia, where Georgia will pay you $76 a visit when you start first coming to the R8C program, no matter what your costs are. I don't even know how they legally can get away with that. I've been complaining for years that we really need to sue the state of Georgia for not following BIPA 2000. So maybe that'll be on our to-do list for this year, is to sue the state of Georgia to get them to comply with BIPA 2000 and pay Medicaid, proper Medicaid rates to rural health clinics. Your Medicare reimbursement, that will be an advantage to rural health clinics in the future, especially independent R8Cs, where in the past, I actually had this on the disadvantage side because you would actually get paid more fee-for-service. Most of you guys will get paid more fee-for-service from Medicare than you would as a rural health clinic. The rates were so just ridiculously low. One of the advantages is your nurse practitioners, PAs, certified nurse midwife. There is no 15% reduction in the Medicare fee schedule. So that is great. That is awesome. That's what it's always been, and that's the way it has continued. Also, we've seen the big advantage of being considered an essential provider. Rural health clinics and FQHCs are considered essential providers. That's made us eligible for all sorts of funds. The rural health clinics received at least $103,269 for being a rural health clinic in 2020 from provider relief funds. Also, RHCs received $49,460.20, or some number that's very close to that, for COVID testing funds as well. And that was arranged through the NARHC. Remember, since 99% of you guys got that money, remember every month you have to report your number of tests that you did and how many were positive. Today's the deadline again for your March 31 information. So remember to report that to that rhccovidtesting.com website that the NARHC handles. So those are the advantages. The disadvantages are you must employ a W-2 nurse practitioner, PA, certified nurse midwife at least 50% of the time that the clinic is open. We're trying to get that law changed about the W-2. The reality is, I hate to say it, but what the state is going to do is when they look at it, they're going to look to see that you've got coverage of at least 50% of the time that the clinic is open with this nurse practitioner, PA, certified nurse midwife. If you've got that, then you're going to pass the survey. They're not as worried about if that piece of paper says W-2 or 1099, but that is, in fact, the law. Hopefully that will change in the future. Poor reimbursement for Medicare for independent, that's, like I said, that's going to go away. I got to change my slide on that one. That one's the one I missed. Kentucky, we do still have Kentucky's sort of a nightmare as far as doing cost reports for Myers and Stauffer. That's the first year you're in the program in Kentucky, you have to do this really extensive cost report, and they will tend to tell you that your providers are overpaid and take some money away from you on that. So that's a disadvantage. Something called negative reimbursement at the beginning of the year. When you bill your Medicare claims with Medicare, instead of them paying you because you basically eat that deductible, and the deductible's 203 or 206, somewhere in that range now, and your Medicare rates are only $87 or now $100, Medicare will actually take money away from you. That's called negative reimbursement. That's always a fun thing to try to explain to your new rural health clinics. And then you have to bill on a UB04 form. So most of you guys that are coming into the rural health program, you're used to billing on a 1500 form. It's very easy for you. You're going to have to change over to a UB04 for billing for Medicare. For Medicaid, each state is different. Some states use a UB04. Most of them do use the 1500 form. To become a rural health clinic, we have to prove that we meet 9 conditions of participation. And those 9 are as follows. Here's this website, www.law.cornell, very easy website. If you actually took the amount of pages that you're reading here, it might be 10 or 12 pages at the most. So there's really not a lot. It's very vague. It gives a lot, it's broad information there. So like 491.4, comply with federal, state, and local laws. That is so vague, it's really hard to tell you exactly what they mean. What we typically do is we put up a sign that says we comply with the OSHA rules and the minimum wage rules and all that sort of stuff. And we do all our credentialing to make sure that our state scope of practice laws are being abided for supervision of your physicians and for your nurse practitioners, PAs, and certified nurse midwives. Location of the clinic, a rural health clinic must be in a non-urban area and a medically underserved area that has been updated within the last 4 years. So you have to meet that. That one's pretty easy to figure out if you meet that or not. Physical plant and environment, you have to have a safe environment, handicap accessible, bathrooms are clean, grab bars, wide halls, no obstructions. Do your normal drills that you would normally do in a practice, you know, a fire drill every year, a tornado drill, those sort of things. That's under physical plant and environment. And organizational structure, you have to have a medical director. That medical director does not have to physically be on site. That changed July 1, 2014. The law changed. We're used to every 2 weeks that medical director had to physically show up on your site with a little log that they would sign in. Yeah, Dr. Smith was here. You do no longer have to do that. There's no time requirement for that. There is something in the interpretive guidelines that says a physician has to, your medical director has to treat at least one visit per year. Now, that's one that's really not enforced that much. It's sort of, again, it's not logical that the physician does not have to physically be on site, but the interpretive guideline says that that the medical director has to see at least one visit per year. So again, that one's sort of again, we can argue about that one because again, that's not a legally binding document that interpretation comes from. So if you argue that one, you'll probably win. Staffing and staff responsibilities, that's your nurse practitioner has to be providing RHC service at least 50% of the time that the clinic is open. And that can be in the nursing home. If you've got your nurse practitioner going over to the nursing home, that time will count towards that 50%. So that's the key one there. Provision of services, you have to be 51% primary care. If you're in Kentucky and you're doing Suboxone, you get a lot of mental health services. As of this moment, mental health service is not considered primary care. What is considered primary care is family practice, general practice, pediatrics, OBGYN. All of those are considered to be primary care, but mental health, for some reason, is not considered primary care at this time. And Kentucky is very good about looking at your HCPCS codes and seeing those codes that if they look like they're mental health, they're going to do a ratio. And we've had a couple of clinics that were 60% mental health and 40% primary care, and we had a problem with the state. We ended up having to drop a lot of our mental health services and keep that ratio below 49%. Patient health records. The key here is, of course, HIPAA. HIPAA's been around since 1994. If you talk to Sarah Batterman or one of your HIPAA experts, they can make sure that you're in compliance with HIPAA. The key thing that we have seen in inspections is consent to treat forms. Make sure that your consent to treat forms are signed within 1 year. That's the key thing that I've seen people get written up for is consent to treats. Program evaluation every 2 years, biennially. You must have a group of people that writes a report. You don't have to have a meeting. There's a little bit of confusion about this. You don't have to have a meeting every 2 years, but you got to write this report. And the report will have to be signed by the medical director, by your nurse practitioner or your PA, and it has to be signed by a community member. It can be a consultant. We sign these things all the time, but it has to be somebody that's not employed by your rural health clinic. And you write up this report and you put it in your evidence binder. You put it in wherever you have to document that you're in compliance with RHC rules, and you can be done with it. Now, what's better is to write up this report and then have a nice little lunch meeting and go over it all with everybody and have a good moment to look at what you're doing each year and saying, okay, yeah, here's what we did good last year, and here's what we could improve on, and here's what our community needs, what we could do, how can we better serve our community? That's a better way to do it, but if you want to write the report and put it in there, and as long as everybody signs off on it, you're going to meet this condition level. And then emergency preparedness, this came about because of Hurricane Katrina, and we saw what a sort of mishmash of response that we had, what a poor response we had to Katrina. And after about 16 years of arguing about it, they finally came out with some rules in 2016, and they became enforceable in 2017. And then in 2019, the Trump administration actually relaxed those emergency preparedness rules for you guys. And so now, every 2 years, You have to have a policy procedure manual that is reviewed every 2 years. There's 24 specific RHC policies and procedures that you need to have in that policy procedure manual, and you have to have a communication plan. That communication plan is a fluid document that changes anytime. If you fire Mark Lynn, you're going to pull Mark Lynn's name out of there and you're going to put in Deshaun's name in there. So keep that in mind, is that communication plan will be updated constantly as things change. And you are required, typically most of the things you have to train your people. That training has to be done every 2 years. Everything is really every 2 years in your emergency preparedness manual now, except your testing of the system. The testing is now, used to be 2 tests every year of your emergency preparedness plan. Now it's only 1. And you can do a tabletop exercise every other year. A tabletop exercise is just what we're doing here. We're sitting on the rear end and we're going over some information, while a facility drill is you got to get out of your chair and you have a fire drill. You have to physically do whatever it is. You have to do that type of drill every other year. And I would recommend reaching out to your community, your EMA directors. You're no longer required to do that anymore. That was a part of those changes in 2019. But best practices say you're going to reach out to your community EMA directors, and you're going to participate in any types of drills that they have as well. So that's really the best practice, and you really do need to do that in order to meet these guidelines. So those are the 9 conditions. Used to be 8. Now it's the 9 conditions of participation that you have to prove that you've met in order to be a rural health clinic. And as soon as we tell you all these things you got to do, there's waivers from this because of the public health emergency. So keep in mind that some of the things are relaxed, like this thing here about having a nurse practitioner or PA 50% of the time. That is relaxed. Don't rely on that. I've got some people. We had a clinic in Illinois the other day that they didn't have a nurse practitioner in the last 3 years, and they said, well, we got a waiver because it's during a public health emergency. And the state inspector said, you haven't had one for 3 years. That don't count for you. And so they had to go out and hire a nurse practitioner, or they were going to get terminated from the program. So be very careful if you're doing that. That was not a good situation. And so here's one where you actually can expand your rural health clinic. Right now, or the way the RHC rules work is an RHC location. When we fill out 855A, it's for a specific location, and you can't do services at another building and bill it as an RHC service to your other location. You can't have like satellite offices. While during the public health emergency, you can in fact have that. Now, I'm not sure. We're testing this in Kentucky. We want to do this in Kentucky, so we're making sure Kentucky Medicaid will actually pay us for this. They should, but we just want to double check with yours. And I would double check with your Medicaid offices and make sure it's okay before you do that. But so look through these waivers. There are some out there that you could use that might help you during this. Also, this document here came out from CMS, where it basically goes through all the different waivers that are available to people. It's like 41 pages long. This document came out in February of this year. I would definitely peruse that one so you can see what waivers are available to you. Here is the location requirement. Again, it has to be in a non-urbanized area. And typically what we'll see is the geographic HPSA. Those are the ones that are updated. These MUAs have not been updated since the late 70s, so you don't even worry about those. Some states, the governor can designate your area as eligible for RHC. I know Iowa, Wisconsin, some places in the Midwest, a lot of times the governors will designate your areas as eligible for RHC. The geographic HPSA is the one that you really want to focus on. That is the one that's the one most people use. And one of the key things to know about this geographic HPSA is if April 30th is the date, it's April 30th, 2021, officially that was the date we were last updated. So May the 1st, we are now out of date on our, within being 4 years. That out of date computation runs through the end of the calendar year. So we can actually still we still will not be out of range until December 31st. And hopefully by now and the end of the year, your state will go in and look at your geographic area and update that HIPAA system. But keep in mind, you have till the end of your calendar year. 4 years includes till the end of the calendar year. So that's very important. I know we've had some people be told differently, but that is the rule. We had to look it up the other day for one of our clients. And I knew that was a rule, but sometimes you double check. Here's your databases to determine if your area is eligible. It's AMI Rural database. It's not 100% accurate, but it will get you there probably 99% of the time. And then go to the HRSA shortage area website and double check. That's the one that's official. So you want to go to that HRSA shortage area database to double check that. If you do have problems with your medically underserved area, Joe Lampard is a friend of mine up in Jamestown, New York. Little hint, do not go see Joe in the middle of February. He's right off Lake Erie and it snows like 70 million inches there. But Joe is really good at this, at anything HIPSA. If you have issues with it, I would call Joe. 98% of the time, he's able to fix whatever issues you have. One of the services that you do have to provide is you have to have the ability to do 6 lab tests. Again, we're trying to get this changed as well. So we have 6 lab tests that you are required to do. You have to have the ability to do. You don't necessarily have to do them, but you have to have the ability to do them. And again, this is not always logical. Again, if you try to use logic with Medicare, sometimes it's going to get you in trouble. Even though you are required to do these 6 lab tests, they are not covered under the RHC benefit. You actually bill those fee for service if you're an independent RHC. If you're a provider-based RHC, using the old terminology, you would bill that using the hospital's outpatient provider number as well. So not logical, but that's what the Medicare rules are. What is the most important aspect of passing the RHC inspection? Having a good evidence binder. And here's the evidence binder, the table of contents that we have for our evidence binder. And like I said, this thing changes all the time. We're always updating it to make it a little better. We're getting better and better at it. And so that is our evidence binder. I would definitely, if you're on that list that you think that you're going to be resurveyed, or if you're brand new, this is one of the first places you want to start, is putting together a good evidence binder to prove that you've met this non-conditional participation. Now, getting into some of the nitty-gritty facts about rural health clinics, independent, there used to be 2 types of RHCs, and this is going to change a little bit with the new law. Used to be an independent RHC that was owned by physicians, nurse practitioners, PAs, and it could be owned by hospitals that maybe they had more than 50 beds, and they weren't eligible to be what's called a provider-based RHCs. Provider-based RHCs were owned by hospitals, and they had less than 50 beds, and they were eligible for an unlimited cap from Medicare, while independent RHCs were capped. Going forward, it's going to change a little bit. And we first started noticing this about 2011. We started noticing that the Medicare fee schedule was higher than the rural health clinic rates. And that's been going on now, that was 9-10 years. Well, when CMS finally, if there's anything good about COVID, was when CMS took a look at this and they implement, now you can do telehealth. You couldn't do that before. And as long as the public health emergency is going, you can do telehealth. And when they put the rate together, they basically took a bundled rate of all the services that you would provide via telehealth. And the average payment was $92.03. You could see that's higher than the Medicare cap for RHC service of $86.31. That's a bundled rate. That includes everything. So if you're doing any types of like injection, if you give somebody a shot of Recephin and all that, that includes all those medications, all those injections, everything. If you're doing procedures, that's all a bundled rate of $86.31. I mean, it's criminal how low it was from Medicare. So what happened was, that's really, everybody said, wait a minute, we are really underpaying these independent RHCs. And so the president signed a law December 28th, the COVID relief package there in 2020 that made some changes. And what what happened was we will no longer have this $87.52 cap for independent RHCs. It's actually gone up to $100 per visit for, and what it is there's two types of rural health. Now it used to be independent provider based. Now there's going to be what we call grandfathered RHCs. And if you're a grandfathered RHC, that means you're an old provider-based RHC that you were certified on or before December 31st, 2020, or you had your 855A filed in Paycos, or it was postmarked by that date. And again, they haven't really finished figuring out everything on that, but those clinics that were grandfathered, you're not going to lose that old rate that you got. You will still get that. I don't know if it's going to be an interim rate or if it's going to be a final, based on a final cost report. CMS hasn't told us that. They said they're going to come out with the new instructions whenever they do the Medicare fee schedule later this summer. They're going to give us instructions on what we call capped rate. It's not going to be a PPS rate. You're not going to get that same rate every year, but there's going to be a cap on how much Medicare will pay you. If your rate before, I think the average for provider-based RHCs was like a $231 per visit. If your capped rate is $231 in the future and you spend, and your cost per visit is $250 a visit, you're going to get $231. If your cap rate is $231 and your cost per visit is $200, you're going to get $200 going forward. So that's for you provider-based RHCs / grandfathered RHCs. That's the way your rate is going to be going forward. If you became certified as what you thought was going to be a provider-based RHC after 12/31/2020, basically our 2021 new certifications as rural health clinics, you are going to be subject to the caps that we're talking about right here. So here's the new schedule for rural health clinics. And this really sounds great if you're an independent RHC. When if you're like me, you look straight to the bottom and you see the $190 per visit, you're like, woohoo, we're getting $190 a visit. No, that's not the case. You're not getting $190 a visit. This is what's called your Medicare upper limit. And we do the cost report every year. We do about 200 cost reports for independent RHCs. If your cost per visit is, let's use an easy year, 2022. Let's do, okay, 2024. Let's do that 24, because I got a question I'm going to ask you in a minute. 2024, it's $139 is the cap. But if your cost per visit is only $116 per visit, you're going to get $116 per visit when you set up that cost report. If your cost per visit during that year was $157, you're going to get $139. That's going to be your cost cap for that year. So keep that in mind. This will become more and more attractive to our provider-based, non-grandfathered RHCs in the future as this gets closer to this $190 rate. This is basically going to put us equivalent to an FQHC as far as our rates go by 2028. When they looked at the fee schedule for FQHCs, which is around 170 right now, and they don't use the Medicare Economic Index, but they use some type of inflation factor. The way the NARHC figured it was we should basically be even with FQHCs on Medicare reimbursement by 2028. So if you want to read more about that, here's the link that will explain that as well. And then we looked at about 20 of our cost reports just to see what the impact would be. We basically had 6 clinics that would get no increase whatsoever because their cost per visit was so low. We had about 3 of them that would get some increase, but they wouldn't get to the full $100 per visit. And then we had 11 clinics that would get the full $100 per visit. So let's see here. Oh yeah, and then depending on what state you're in, I'm using Tennessee as an example, and nothing logical about this at all, nothing whatsoever. If you have less than 8,000 visits and you live in East Tennessee, Medicaid's gonna pay you $178 a visit. If you have 8,000 to 13,999, they're going to pay you $131.66. We had a clinic that had 8,020 visits, and they got $131.66. So if you're in Middle Tennessee, 161 or 146, and it has nothing to do with cost. They just have a little schedule that they pay you for it. And so nothing logical about it, but what you want to do is find out how your state sets the rate, because they have to use what's called BIPA 2000. That's the law, but the interpretations are different in every different state. So very interesting there. Let's go ahead. I got a poll question here. I'm just going to see if you guys are paying attention and see if I have the ability to do this. Let's see here. Select a poll. Okay, here we go. Poll is open. Okay. If you will, go ahead and try to answer that question there. The poll question is, how much would you receive based upon, I don't have the question in front of me. Where's the question? I never do these. Deshaun always does these for me. So, or
So
Danny.
they're answering them now, sir.
Let me see here. And
Yes, sir, Mark. They're answering them now. The votes are slowly gathering.
now you can see how terrible I am at this. Okay, so the answer to the question is, you guys are doing good on this. I'm gonna give you just 5, 4, 3, 2, 1. Let's see here. Okay. And I believe the answer was 109. That is the correct answer. 45% of you got it right. 30% of you said 100, and 15% of you said D, the grandfathered rate. So the right answer, I believe, was $109. Let me see. An independent.
Yes, sir. Majority of the population selected.
Independent REC has a cost per visit in 2022 of 109. How much would their AIR rate be? And in 2022, the cap was 113, but their cost per visit was only 109, so they would get $109 per visit. So that's let me see here. And so there we go. There's the answer. This is really hard, Deshaun. Who's here with me anyway? Is it let's see here.
Yes, sir. Can you hear me?
So perfect. All right. So you guys, that's why it's so confusing. That's why we had so many wrong answers there. Your rate would be 109. That's what Medicare would pay you in that particular situation. So which specialty does best in the RHC in the past? Again, this is a little bit dated slide. It's going to be pediatrics do extremely well in the independent RHC program, which is surprising because you think Medicare. Pediatrics do just extremely well, depending on which state you're in. If your Medicaid programs are very attractive in those states, we've seen pediatricians do extremely well. So you want to look at that. Okay, I'm running long on my time here. Let's go ahead and do these last slides pretty quickly. Projected timelines to become an RHC, and you have to do an 855A approval. Basically, you're just seeing if you're a good person or not. That takes about 2 to 3 weeks. Now, it used to be 2 to 3 months, but 2 to 3 weeks during the public health emergency, and you do not have to pay the $600 fee. So it's a great time to be a rural health clinic because they can get you approved with your 855A very quickly, and it doesn't cost you anything. Certification and inspection. Let me see here. Okay. Okay, we'll go ahead. Sorry about that. Certification inspection, that normally takes about 2 to 3 months, and then getting everything set up for you guys to get paid. This is what I call the trough of disillusionment. Typically takes anywhere between 3 to 4 months to get your rate set, to get your CCN number. If you're in the Dallas region, for some reason, it takes them forever to get a CCN number in that particular region. In Atlanta region, it may take you 2 weeks at the most. In the Dallas region, it may take 4 or 5 months to get one-page letter. It's so annoying. That's where you really do get the trough of disillusionment. First steps, get a banker. You will need a line of credit because we're going to ask you to hold Medicare and Medicaid claims at the very beginning, and you're going to need some way to pay your bills during that period of time. This is what I call, like I said, the trough of disillusionment. You become a rural health clinic here, you pass your survey, and you expect money to come flowing in like manna from heaven. It ain't that way. You hold your Medicare and Medicaid claims for about 2 to 3 months to get all of your billing set up, to get enrolled with the state as a Medicaid, as an RHC. It takes a pretty good while to get that money in. So that's going to be important. Also, when you set this thing up, make sure, this is probably this is even the more of the first step, is you do not want to be a sole proprietor when you become a rural health. You can be an LLC, but do not be a sole proprietor, because if you as a sole proprietor get an RHC, a CCN number under that, when you die, that status goes away. You want to be an LLC so you can switch it over to somebody if you need to sell it, or because you'll want to sell it before you pass away, hopefully. So, but it is an advantage of something called value of services. You don't draw a salary if you're a sole proprietor. So keep that in mind, but become an LLC. An LLC, you can have a partnership as a part of an LLC, and you can use what's called value of services. While if you're a corporation, there are some benefits to that, some fringe benefits, and you do have to pay yourself a salary, which can be good to actually withhold all of your taxes for that. There's just a little bit less of we can't be as creative in computing your compensation as we can with the sole proprietor or partnership or LLC there. So just talk to your tax accountant, talk to your cost report person before you incorporate, if you're getting to this point where you're starting a business and want to be a rural health clinic. Okay, finally, resources here. There's the website that we showed you before. Chapter 13, this is basically the Bible. There's also chapter 9 as well. Those, you're going to find a lot of billing guidance for rural health clinics. The National Association of Rural Health Clinics does a great job in informing everybody, and I definitely recommend joining that and going to all of their meetings. Here's Appendix G and the CMS 30 survey form. They actually give you the form that they use to survey you as well. So, and here's the surveyors. If the state will not come out and do an inspection, either Quad 8 or the compliance team will come out. It costs money to hire them, but both of them do a great job. I'm agnostic on who you use. I love both of them. Elsie and Kate, they're all wonderful, great friends, great people, and great organizations. So either one of those is good. This one here is actually, this is a nice homework assignment. If you guys are going to be surveyed soon, what we did is we took Kate and Elsie and we did a virtual walkthrough of a clinic and just asked Kate, okay, Kate, when you go into the exam room, what are you looking for? And Kate told us, and then we would go to the next room, and Elsie, when you go to the lab, what do you look for? And so, for the Quad A person there. So that's a really good document for you. Again, you should become a rural health clinic professional. I became one. It was a great course. It's really good. You have to take a test and pass it, which is shockingly I passed it. And so definitely recommend you doing that. That's something that's very good. Also, the National Association of Rural Health Clinics has a listserv. We have lots of information on there where you can ask questions as well. And they have technical assistance webinars that are great. So you want to take a look at those as well. And that one there, hey, I did that one, Rural Health Clinic cost reporting. So they let me sneak in and do that one. Again, the future is really bright for independent RHCs, better than ever for provider-based. We're going to be going through sort of an adjustment period because of losing the unlimited cap. So we're going to be thinking differently about how you use rural health clinics in the future if you're provider-based. So I think that's all I have for questions here for my presentation. I only have 2 questions here. Let's see here. Question here from Brittany is, do the consent to treat forms have to be updated yearly, or will the initial form suffice for this requirement? The answer is they have to be updated annually. So yes, you definitely, and they will look at it. What typically a surveyor will do is they'll look at 20 charts and they'll go through those charts and see if those consent to treat forms have been updated and been scanned into your EMR. And if they haven't, then they will write you up for it. And it's a pain to fix that one because you've got to monitor it every week. You got to monitor your compliance, and it's a pain to fix. So get those consent to treat forms signed within 1 year. Can you answer a couple of questions about negative reimbursement and Alabama Medicaid? I doubt it. Does Alabama issue a rate letter for new credentialing? Yes, they will do that. Yes, they will give you a rate letter once you become a rural health clinic. But I'm not sure about how to answer the negative reimbursement part. Okay, we've got a hand up. Let's see if we can follow. Let me find. Okay. How do you handle a minor for consent to treat? If different parents bring them in, the guarantor is the parent who is responsible, but we only get the consent. How do you handle a minor for consent to treat? If different parents bring them in, the guarantor is the one who's responsible, but we only get the consent signed once a year. Yeah, I mean, you just have to work through with the family on that one. Just try to get those consent to treat forms signed at least once a year. Otherwise, like I said, I've seen a bunch of people get inspected for that. In Georgia, how long until you get inspected again? It's a long time. Georgia is the one state and I haven't done an independent RHC in Georgia in 20 years. That's how low the rate is. And Georgia doesn't really come out that often. I think it's probably every 6 years in Georgia. When I looked at that schedule this morning, it's like 50% of the clinics had not been surveyed, and it was the one that had the most that weren't surveyed. Let me see here. Are we in danger if we do not have our current 1230 filed when they set provider rates this summer? Don't know the rules on that one yet. They have not released the provider-based rules. That will come out in July of this year. We don't know if they're going to use an interim rate or if they're going to use if they're going to use an NPR rate, which to me, I would think they would use an NPR, a final rate, after the cost report has been audited. Okay. And Run-In, thank you, Run-In, for all you do. I love your videos, and every week definitely join the Oregon Office of Rural Health. At least subscribe to their channel because it's great. For Medicare negative reimbursement, bill charge minus contractual, max billed, patient or secretary, what is that correct? The remits are crazy. Yes, we have to spend a whole webinar on negative contractual. Basically, the key is you need to balance to what the Medicare copay or deductible is from the patient. Because Medicare withholds money from you, don't be charging that money to the patient. So the quick and dirty answer is, if Medicare says that Mark Lynn owes you $206 deductible, then make sure Mark Lynn's account balances to 206, and whatever the difference is, you're going to write that off as a contractual adjustment for that. So we'll probably have a session just on that. Okay, and let me see here. I got hands up. Let me make sure. And okay, Angie, I've got you muted, but now Angie, your line is open. I don't know if I'll be able to answer it in the amount of time we have on negative reimbursement or how Alabama handles it, but you're welcome to ask me any question. Your line is open.
That's all right. Thank you. You answered the question as best as you could.
Angie, can you hear me?
Oh, I can.
No. Okay. All righty. I'm gonna close that one out then, and I was scared to try to answer those questions anyway. Okay. All right. Thank you. Okay, Angie. Thank you. Okay. Okay. Here we go. We have one final question, then we'll close it down because I see the time is 2:03. If I'm looking at establishing a provider-based RHC, should I also get a Medicare Part B number under the RHC MPI number for non-RHCs, or can we use the hospital outpatient Part B number? Use the hospital outpatient provider number. You do not have to get a new MPI number if you're provider-based, Sarah. So, okay. All right, we're a little bit over time here. Let's go ahead and close it down. Thank you guys for attending. We really appreciate it. And we'll let you guys get about your day. Have a great weekend. Thank you.